So I'm talking about integration of primary care in the GP setting in Australia. These are my disclosure of interest. So just a quick couple of things, just a slide showing, HBV elimination. We're still not reaching our goals in a lot of parts of the world, and pretty much the same with HCV as well, which is what I'll be focusing on. So I'm focusing on really much about the HCV management in primary care in Australia and the model we actually use there. This is just a history of all the treatments available, where really since the last 10 years we've had really good treatments of directly acting antiretrovirals and also pangenotypic treatments. And there are already studies in Australia focused on management of HCV in primary care settings because we've done that for a while now with very good results, SVR rates of 98%. And this is just a slide. A lot of these slides are from the Kirby Institute website, and this is just showing the breakdown of HCV treatments across different settings. And the dark setting is the general practitioners, which is now the majority of where HCV treatment is delivered. And specialists and nurse practitioners are the smaller groups. And Hep C notification rates have dropped a bit, but we're still looking for the hidden cases in Australia. And these are testing rates in access clinics, which are sexual health and LGBT clinics, HIV clinics, where we do a lot of HCV testing. So testing rates are fairly high, and clinics are ours. Pretty much most of our populations have had HCV testing, so we're looking at other places for where the hidden population is. So I think there's an important role for primary care in hepatitis management. I think just to set the scene, general healthcare in Australia is public and private funded. In primary care is pretty much GP clinics. General practice is generally privately funded, so owned by doctors and companies. So patients will come to us for health services, and they usually pay for their services and they get a rebate back from Medicare. Clinics like ours also offer health services just for the rebate, so patients are not out of pocket. On top of that, testing, so pathology testing is generally government funded, so it's not paid for. Medications are mainly funded by the government, where there's a cap pricing. So for any medication that's funded on the government system, it's $30 per month that a person has to pay. For low-income earners, it's $7 per month. So that's how our health system is set up. So I think there's an important role in general practice for us, because I think we educate our patients about risk prevention strategies. We can do the testing and follow-up. We also do vaccination, and I think we should be doing treatment more and more. So it's important for us to educate general population about hepatitis. So, we see the general population for everyone. In practice, I see LGBT, HIV patients. We do drug and alcohol services as well, so we see that population as well. And we see just general population as well coming for just overall general testing. I have a special interest in people who use anabolic steroids, so they come for blood testing. I opportunistically ask if they actually want blood-borne virus testing as well, so we do additional testing. We also talk about lifestyle, sexual risk, injection risk as well to them, and we can talk about prevention measures with these people. So we often will do routine screening in all the populations we think are appropriate, and just offer them generally and discuss results, and we have additional opportunities to educate them. So for example, someone has a hepatitis test, we do some education when they actually come and get the test, and when they come and get the result, if it's negative or positive, we can do additional education as well for these people. So we do vaccination generally. In Australia, Hep B vaccination has been a general vaccines in children for probably 30 plus years, and hepatitis A we only vaccinate for at-risk groups, which is gay men and people who are traveling. So my point is hepatitis treatment can be treated very effectively with primary care. Like Dr. Sayada said before, I think the treatment flows are quite straightforward nowadays. There's no reason not to actually roll it out to GP clinics. There are minor barriers, and using Hep C treatment. So initially this was the issue, identifying the population, finding available treatment, the cost of treatment, access to treatment, monitoring and follow-up, which are the things we had initially. So identifying population, injecting drug use. So clinics, a lot of clinics will see people who inject drugs. not only intravenous, but other sorts of injections as well. I think it's important for general practices to be asking people about their practices and whether they put themselves at risk, gay and bisexual men as well. In Australia, there's this whole unidentified group because it's a population of people who have tested HCV in the past, who haven't presented for treatment, and we're not sure why or where they are. So, but general practices are more likely to come across these people in just general healthcare. But yeah, so primary care is an important thing. So cost of treatment in Australia, 10 years ago, treatments were available. There were significant costs, but in Australia it has been funded. I know the funding is very different across the whole region, where generics will reduce the cost for some areas. In Australia, initially, we had the genotype-specific treatments, but now with the pan-genetic treatments, it's much more straightforward. And we had DAAs available since 2016 for chronic Hep C treatment. So the costs, medication and costs overcome by the government, and like Dr. Rosa said, it does involve government actually making it available at a reasonable cost. Increasing testing, we had partnerships to the community, to GP clinics, encouraging more testing and giving access to treatment through different facilities. So initially one of the barriers that people had was people had limited access to hepatitis clinics, which is obviously where a lot of the treatment was initially. Thankfully for us, the ID physicians and hepatologists very early on realized that they could not provide this care for everyone. So they were actually encouraging GPs to start taking it up. I think that makes a big difference to have the specialists in your region promoting this as well. And the whole issue was about people with cirrhosis needing to be actually treated differently potentially. There's very little availability of fibroscans even in Australia because it's not funded within the government funding system. And when we started doing it, basically, we very quickly switched across to using an RP score to screen out people with high risk of fibrosis. So majority of people have very low risk, and they went on to treatment without any specialist involvement at all. So monitoring, so we do the monitoring as well. I'll show you there's a flow chart later on what to do. We monitor for the virologic response and continue education to prevent reinfection. And we do further treatment and testing as required. So ASHM in Australia, the Australian Society of HIV and Hepatitis Medicine, produced these sort of things. You can look at this online. So decision-making hepatitis, very simple flow charts for GPs to follow, where it goes from the testing and the treatment, quite comprehensive and very, very easy to use, and education things for doctors and GPs to do. And same for hepatitis B as well. So I think that's important to have very easy resources. I suppose every country is different as well. For Hep C treatment in Australia, you don't need to be in any way extra qualified for it. Any GP can do it as long as you're comfortable. There are lots of guidelines available. When you're doing the prescription, there are actually guidelines on the medications themselves as well, so you can access that as well. Hep B requires a bit of extra training because there's some complexity in managing chronic Hep B, I think. So current role, primary care Hep C management in Australia, we do education, we do the testing, we can identify the at-risk population, we can test wider for people who might or might not think they have risk as well. We look after people who inject drugs, we look after people who have sexual exposure, who might have past history of exposure that they haven't talked about currently. So diagnosis and treatment or referral, so we treat most of the hepatitis C cases. Occasionally we refer one with complications or have risk of cirrhosis. And we also organize the monitoring and follow-up. We look after the virological response, treatment failures and reinfections, where sometimes we would refer back to the endocrinologist. So in summary, I went through this very quickly, didn't I? Australia's Hep C response required multiple stakeholders. I think that's really important because the government needs to be involved with it, and they need to allow doctors to actually treat Hep C more widely. They need to actually secure the funding for affordable Hep C treatments. I think there needs to be a collaboration between different organizations, specialists and primary care, and obviously in different settings. There might be nurses, nurse practitioners, community organizations to actually collaborate to roll out this Hep C treatment wider across the community. I think there needs to be promotion and testing, which involves community-based organizations and governments as well, to actually promote testing as well as treatment for at-risk communities. And even in Australia, there are still many unidentified, untreated cases of hepatitis C that will require further work, further collaboration, and further action in this field. Thank you very much.